So excellent. Hi everyone. I was told that the webinar is viral. So a warm welcome from Budapest, Hungary, to dear colleagues and ladies and gentlemen. It's a very nice weather outside. It's 24 degrees centigrade. It's a very nice warm evening. So let's start what we would like to talk about, and that's simple as that. Let's jump into the details. So if everyone have a look at this nice picture, let's have a couple of seconds to discuss what we can differentiate. So it's quite simple to see that the keratinized gingiva here is quite firm. Nevertheless, if we look the other side, if we look the upper left or lower right quadrant, you can see there is something missing there. So let's see what is the result of this. On the lower right quadrant, what we could say is a total lack of keratinized mucosa here. So that's just a mobile mucosa. And if you check the probe with a very nice tool of the periodontist, the periodontal probe, you can see that we're almost 9 millimeter pocket depth. So I'm sure everyone is curious of the X-ray, what this picture looks like underneath the soft tissue, whether it is a tooth or implants, and yes, these are implants. So what we can see in the picture, that in the lower right premolars we have implants, the molars as well, and see if you pay a little attention on the green arrow, you could see that there is firm, thick, keratinized attached mucosa. Nevertheless, there's a locking here, so there's none. And we can see the result on the picture. Let's have a look at the upper left-hand side. Looks pretty much the same. We have nice, firm keratinized mucosa here, but we don't have anything here, so the mucogingival line is there. And obviously, everyone sees that this is a nice titanium tissue. And if you press, it's not only inflamed but pus discharged from the implant as well. And of course, as I'm sure everyone would predict, that there is a peri-implantitis. I'm not saying, of course, that this peri-implantitis and this pus discharge is just because of the lack of peri-implant keratinized mucosa, but it's a crucial factor. And we're going to have a look later on why. Again, upper right quadrant of another patient, nice, firm, attached mucosa here, and none there, without any vestibule. And of course, we can probe the pathological pocket around the implants. And the last case for the introduction, to make our evening more interesting, this lady. This lady sent to our practice with some discomfort in lower jawbone. Nice implants have been placed, not in an exactly correct position, but good quality implants there. What we could see is that again, no keratinized mucosa and very extremely shallow vestibule. So it looks like if we try to pull the whole buccal side on the lower left side, we can see that there is none vestibule here. And as I said, it's nice, good quality implants, all Straumann implants, soft tissue level implants, and not a deep bone resorption has been started. And the vertical dimension of the bone is still there, but even with good quality implant, even with, let's say, acceptable bone levels, without keratinized tissue, without soft tissue, we can't be successful. So not 100%. This is a picture when we just 1 or 2 weeks after we've done a vestibuloplasty and widening of the keratinized mucosa. In the left-hand side, the right-hand side will be coming later on. It's just to show that yes, we do have bone and we do have vestibule, and just we have to take into consideration. And if the patient doesn't have, because of the extraction, we have to, or it's advised to reconstruct. So ladies and gentlemen, dear colleagues, again, a very warm welcome to Budapest. My name is Attila Horváth. I'm an assistant professor here at the Semmelweis University, and the reason I took the privilege, reason to have here and give you some details on keratinized tissue is in the last couple of years I'm a little bit involved in that topic. So let's have a look what we would like to cover today. So I take a very wise and well-known sentence, a quote from Dr. David Garber. The bone sets the tone and the tissue, but the tissue is the issue, is the tissue. So most probably he was considering soft tissue like this. Or, of course, in the European Union we have to be politically correct, as we all know. So soft and hard tissue in order to please our nice ladies audience. Maybe Dr. Garber considered this, maybe not, we don't know, but let's get back to the oral cavity because I think it's more important for us. And let's just have only one side on anatomy. So mobile mucosa, mucogingival junction, keratinized gingiva, and the papilla. So this is what we would like to cover today. But you might remember I sort of mixing keratinized gingiva and attached gingiva, keratinized mucosa and attached mucosa. I was wondering when I was preparing to this lecture that what is exactly the difference, because in the literature and the congresses we keep listening and hearing this different issue. To be honest, it's very simple. Attached gingiva is from the mucogingival junction through the attached part of the gum, because this small papilla or the marginal gingiva is called as free gingiva. So this is macroscopic structures. Nevertheless, keratinized gingiva are the both. So histologically, because keratinized tissue is a histological terminology, it consists both. Consists the free gingiva as well as the attached gingiva. So let's have a look and let's talk in the next half an hour on histology. Just kidding, of course not. Monday evening. So this is the keratinized tissue, and this is a nice picture of the non-keratinized tissue. I'm sure all of us remember from our undergraduate studies, sleeping on a microscope, that non-keratinized in the lower jawbone and the lower picture means that we can differentiate and see the nuclei of the cells. On the contrary, in the upper picture, the keratinized tissue, there's just a keratinized layer, so hyaline layer with granular cells. So it's sort of a protective layer compared to the non-keratinized. So why is that? Because the whole difference is back to anatomy and back to function. The keratinized tissue, as we see in the human or we see in other mammal animals like the horse, this is for protection, for mechanical protection. So it's exactly the same in the other part of the body as well as around the tooth. The keratinized tissue is there and created in order to mechanically protect our periodontium and on our tooth. So let's see what does the literature tell us about the keratinized gingiva. So I found, and I quote a nice old study from Vador that it was a 10-year prospective case series, and in special clinical situations they investigated the mucosa. A special clinical situation means that around iatrogenic circumstances like crowns and bridges. In case of lack of keratinized tissue, there was an increased inflammation, an increased attachment loss, and increased gingival recession. This is what they found in the case of lack of keratinized tissue. Now, funny enough, another group has done this research vice versa in 30 years later. So in case there was a lack of keratinized gingiva, so less than 1 millimeter around fixed partial prostheses like bridges and crowns, they actually did connective tissue grafting with reducing a significant gingival augmentation, and what they found is reduced plaque, so less plaque, less and reduced inflammation of the gum, and the attachment loss has been reduced as well compared to non-grafted side. So the literature, of course, we can talk a lot about the literature, but I think it's in Monday evening is not the ideal and the best program for us. So let's summarize what the literature tells us on keratinized gingiva. So the presence of keratinized gingiva does not seem to be necessary in obtaining to health of the mucogingival complex, but the minimal width could be beneficial to facilitate oral hygiene, and that amount, according to studies, should be between 1 or 2 millimeters. So lack of sufficient keratinized gingiva ends up with or leads us to difficulty in oral hygiene, plaque accumulation, gingivitis, recession, that, as we know, might lead to periodontal distractions. And to be fair, all this could be prevented by excellent and perfect oral hygiene. But also the literature tells us that increasing the width and thickness of keratinized tissue that is associated with positive results. So what I believe we aim to do is increasing the keratinized the width of the keratinized gingiva, increasing the width of the attached mucosa as well, and the vestibulum as well, to deepening the vestibulum. And of course, we'd like to see the result on the long run. Now, just in brackets in one fact that width, I was talking on width. Of course, it means height if we're talking vertical position from the mucogingival junction to the margin of the gum. But in the perio literature, you know, I'm periodontist, and I can say that we are sort of a funny type of people, because the height, we call it width. So of course, if the patient is lying in a horizontal position, that is height, but of course it's not the case. So anyway, just to clarify, when I'm talking the width of keratinized gingiva, of course everyone is considering the height. Okay, so this case on teeth is from one of our publications, recent published publications from Dr. Kerber and Professor Guerra and myself. And if you have a look, in this case, we did have a very, very thin and narrow keratinized tissue, and almost non-vestibulum here at the lower right central incisor. So the treatment plan was to do 2 surgeries. The one is to do vestibuloplasty and biotech modification, so increasing the width and thickness of keratinized tissue, and then another surgery to do the recession surgery with modified coronary advanced flap, for example. So this is what we've done, the good old ECTG, or formerly known as FGG graft from the palate. Took the fatty cells, prepared the recipient bed, nicely trimmed the graft, placed there, and immobilization. I think immobilization, I believe, is absolutely crucial, not only around teeth but also around implants, because the tight contact to the periosteum is absolutely crucial, because all the nutrition is gonna come from there. So let's see the results after 2 weeks, 1 month, 6 months, and a year and a half. So the tissue is maturing. It's not as pale as we predicted ECTG graft, but let's have a look what happened after 2 years. After 2 years, actually, the recession is almost disappeared. It's almost done, almost gone. The patient has a nice smile. She's very happy. So if you see if you have a look in a larger magnification, we see that the previous width of keratinized tissue was that which has been increased like that, without any coronary advanced flap surgery, just modifying the biotype. So we haven't done anything. The second surgery, just the first surgery, biotype modification, attach keratinized gingiva widening, and this is the result. And of course the patient said, thank you, I really like the surgeries, it was a very nice experience, but if it's not necessary, I don't want to go it again. So I'm very happy with the result. So this is done. Nevertheless, of course we're starting with these because mucogingival surgery came from the good old 70s, I would say, from the from peri surgeries. But as we see in the website of botiss, they're dealing with bone and tissue and implants and regeneration. So the topic today is not the gingiva, not the teeth, but keratinized mucosa around the implants. So let's see some implants. Before that, we have to stress that there's a huge difference between teeth and implants. And that is A, the biological width, B, because that's much deeper at the implant compared to the teeth, nutrition. Because of the periodontal ligaments, the teeth have the nutrition from there through blood vessels. Alongside the implant, there is none because of the functional ankylosing, so there's less, the nutrition is much less. And the third important thing is that the connective tissue fibers, they attaching perpendicular to the cementum compared to the implant where it's just a parallel fibers. So the attachment is not as firm at implant compared to the teeth. And also some minor differences in terminology that we call it obviously keratinized gingiva at teeth and peri-implant keratinized mucosa at the implants. So again, let's have a look what the literature tells us on peri-implant keratinized mucosa. So I quoted two papers. The one is from Kim et al., so the Kim family or dynasty. Well, they investigated 276 implants and 100 patients, and which is quite a nice number. And the parameters were inflammation, gingival index, plaque index, pocketing, recession, and bone loss. Now let's jump to the results. So they did not find any statistical significance in the plaque, pocket, and gingiva index. Nevertheless, in absence of keratinized tissue, the gum recession and the bone loss was significantly more. So that was a statistically significant difference in the case of reduced amount of keratinized tissue. So they concluded that in case of small or not enough keratinized tissue, might induce gingival recession and crestal bone loss. So for long-term maintenance and aesthetic, the presence of appropriate amount of keratinized tissue might be required. So let's have a look at another study from Bull and co-workers from 2008, quite similar. They measured and investigated implants without a sufficient amount of keratinized mucosa. They said less than 2 millimeters. That was the narrow zone. And what they stated in the results, that plaque score and radiographic bone loss were significantly higher for those implants with a less keratinized mucosa or less thick or width of keratinized mucosa. So they concluded that increasing the width of keratinized mucosa is associated with lower alveolar bone loft and improved soft tissue health. And now I suggest everyone have a short think of their own practice. I'm sure everyone here in the floor are specialists in implant dentistry. You've done a lot of implants. So in your practice, if you recall, were the results exactly the same when you had enough or at least 2 millimeter band of keratinized tissue when the implant or not? So until you're considering the answer, funny enough, I've been to a concert in the summer, a very nice Guns N' Roses concert, and Axl Rose put the same question. So whether per-implant keratinized mucosa matters or not? I got a quite subjective answer, which I think, yes, it does, but of course it's not evidence of the literature. So let's look James Hetfield, which is a stronger evidence of literature than me, and we can see that he stated that nothing else matters but per-implant keratinized mucosa. So that's a piece of evidence. But of course, you would like to have systematic reviews because that's a more stronger piece of evidence according to Ian Needleman, and he's absolutely right. So let's have a look if any systematic review have been published recently on per-implant keratinized mucosa. And yes, a number of reviews have been published. So from 2012, Vanstrom and Dirks stated that when per-implant keratinized mucosa is less than 2 millimeters, then it is associated with significant higher plaque and bleeding scores. Another review. The results of the systematic review show statistically significant differences in plaque index, gingival index, and mucosal and attachment loss. So that's bone loss. And all the study favored implants with wide keratinized mucosa. Another study, another review. Gingival plaque index and modified plaque index were significantly higher in the group with keratinized mucosa less than 2 millimeters. And modified bleeding index was not high but not significant. And there is a quite recent review from Moracini last year. It is a systematic review of the systematic reviews. So the top, the Chomolungma, or if you're in Europe, a Mont Blanc of evidence. And they stated that all systematic reviews included reported a positive association between an adequate keratinized mucosa, which is equal to or more than 2 millimeters, and peri-implant health. Nevertheless, we are all in academic, so we have to state that heterogeneity was highly significant in the studies, and we have limited evidence on bone level changes, and unfortunately long-term data are still missing. Okay, so based on this, what we may presume that in case of narrow keratinized mucosa, narrow band of keratinized mucosa, that might be associated with poor plaque control, bad oral hygiene, that will induce increased bleeding and peri-implant mucositis. That is quite a strong evidence. We don't have as small evidence as sound evidence, but it's still pieces of evidence in literature that next step might be peri-implantitis, attachment loss, and of course recession and associated with marginal bone loss and implant loss. So based on this, in my personal opinion, is we replace per-implant keratinized mucosa wherever possible. Now the question is, the second part of the lecture, how do we do that? So we have a different and several grafts, of course. The good old free gingival graft, the mother of all grafts, that is, if we just check the terminology, it is connective tissue graft, of course, which is connective tissue. And there's so many different parts of this graft, because free gingival graft means, in my opinion, as the free part of a chunk of the gum from the palate of the oral cavity. It could have connective tissue, subepithelial connective tissue, epithelial tissue, and so on. So the literature divided the different parts of the tissue: subepithelial connective tissue, below the epithelium, epithelialized epithelial connective tissue, which means epithelial and the connective tissue underneath, and partial epithelialized connective tissue, which we will discuss later on. And of course, we have apart from autografts, we have other grafts like allograft and xenografts from different material and species as well. So how can we replace that? Autograft, allograft, xenograft, and combinations. So the first one is the autograft, which is the epithelialized connective tissue graft. Then subepithelial connective tissue graft could come into the picture, and partial epithelialized connective tissue graft. In terms of allograft, we should take into consideration the acellular dermal matrix like alloderm or dermal graft. In xenograft, we can find in the market xenogenic collagen matrix like mucograft and mucoderm, and combination of this like strip graft and xenograft like mucoderm. So let's discuss this in a little bit more into details. Autograft as a first choice, so epithelialized connective tissue graft, again formerly or widely known as free gingival graft. So I brought you a nice example. This patient came to the office with a difficulty in brushing, because in the lower jawbone he said, well, I have a little bit of a pain on brushing, there's a bleeding, and if you took the very difficult and dangerous weapon of the periodontist, the periodontal probe, and the press into the pocket, we can see that we can measure an 8 to 9 millimeter pocket, which is not the meaning of long life of a tooth on an implant. So then the patient already came with a CT scan, and unfortunately on this CT scan what we could see that these two structures under this, whatever we call it bridge, we call it maybe just a hat or whatever. So underneath there are two implants, and as we see in the CT scan, the bone level is not in the ideal position at all. So now we could put a question again to us or to everyone else, that in that situation, how should we go on? And now I kindly ask you to take a few seconds and to discuss and consider what to do. Extract these implants or leave it and do some regenerative, maybe resective surgery, or leave it as it is. Now, since it's a webinar, of course, this is a drawback that I can't see you, but I'm sure everyone has a nice solution. I tell you mine. I'm not sure if it's the best or not, but I told the patient that, well, I'm a periodontist. I like to keep structures like teeth and implants, but this is, I believe, beyond our limits. You'll be better off to extract those implants. Let's wait for the healing. Inflammation is gone. Then do a proper bone augmentation, proper GBR, then most probably a proper soft tissue grafting, because you don't have any keratinized tissue. And afterwards, we can place 2 implants, and afterwards, a prosthesis. Which means is, I would say, a year and a half, easily. Patient was very kind, he said he understands my point, but he doesn't want to let these implants explanted. So what other option do we have? And actually, I thought that, okay, let's take this structure off, let's do some non-surgical cleaning. And also, I've seen that there is not much keratin gingiva, so let's reconstruct this tissue. And I was hoping that the patient in that time will be ready for the explantation, and we can do the job, we can make the job done. So if you have a look when removing these bridges, we measured a nice 7mm pockets, and see the mucogingival junction. It's not in the ideal position here at all. I would say the width of keratinized mucosa is even minus 2 to 3 millimeters. So what we've done in this situation, let's go ahead. We've done a non-surgical cleaning as well as ECTG grafting as a normal and good way to take a nice graft from the palate. In this situation, no, it's not the palate. We took it from the tuber side because of the lower mobility and the better quality of the collagen underneath. So we found a nice area here written ECTG. So I couldn't stop me to cut this out and cut it half and place into the nice donor side, a recipient area. And of course, in the same time, we've done non-surgical cleaning of the implant in order to reduce the bacterial load. Nothing else. We haven't done any open surgery. We didn't disclose the threats on the implant. So 2 months post-operatively in this picture. Okay, a little bit delay in the computer. Good. And this is the new line of mucogingival junction. So we gained a nice amount of keratinized tissue, and we still have 2 to 3 millimeter buccally to the implants. That was previously, and this is a nice tissue now when we can see the Hungarian national flags on the picture. So 3 millimeters, 2 millimeters. And interestingly, when I measured the pocket, there was a reduction observable in the implant because there was 4 and 3 millimeters of pocket depth right after, 2 months after the soft tissue surgery and the non-surgical cleaning. So we took an X-ray after 2 months postoperatively, and instead of the bone level, which was somewhere there, now we could see and we would observe a much higher bone level. So of course it looks delusive, so it looks much better. If I've seen this picture in the very beginning, I wouldn't say to the patient that these implants are for extractions. But we took a CT scan to see the truth, and if we see that yes, the bone level is somewhere there in the cross section, the bone level is yes in the middle of the implant, and the 3D picture shows a nice amount of bone as well. So please don't get me wrong. I'm not saying that with connective tissue grafting, epithelial connective tissue grafting, we created bone. I don't think that's the issue. Again, remember what we've done in the perio case. We just reconstructed normal biology, Mother Nature. So we get rid of this awful crown, we clean the implant, reduce the bacteria amount, we reconstructed the healthy keratinized and attached tissue, and most probably the bone which was always there but demineralized. The body somehow recognized that, okay, bacteria is gone, I'm in a very healthy situation again, so let's remineralize this peri-implant tissues. So just to highlight, the message for me was that I should not consider and take final decision on an X-ray without trying improving the soft tissue and reducing the bacterial count or reconstructing the biology. So out of this question, out of this picture, in 2 months we achieved that. So I think it's acceptable result. But of course, the best treatment is prevention. So let's have a look how should we reconstruct peri-implant keratinized tissue, not when the problem occurs, but previously. So in this situation, the mucogingival line is exactly a line, so it's just right there. Again, -2 to 3 millimeters per keratinized tissue. So let's see what we've done in that situation. We tried to reconstruct this width and band of keratinized tissue. Again, we took a nice band amount of ECTG, epithelial connective tissue, and transplanted from the palate to buccally. It's a huge chunk, of course, but when we have implants already, it's a good start to reconstruct this tissue. Of course, the morbidity is a little bit high in that patient, so in that situation, I was very happy to stay on the blunt end of the scalpel and not the sharp one. But after 2 weeks, since we see the stitches there, it's quite a nice and fast healing. Vascularization. After 3 months, what we could see is a firm and adequate amount of keratinized tissue around the implant buccally. And when the prosthesis has been delivered, we could see that we still have that result. But as I said in the beginning, is it stable for the long run? So I can tell you the 3 years result, and still we have a good 4 millimeter and 5 millimeter keratinized gingiva around the implant. So it's really stable, and if we check the X-ray, the situation was after GB lateral augmentation as well as sinus lift surgery. So the implant is on the right position, and hopefully it remains since we created the healthy biology. Now, in order to reduce the morbidity and the pain discomfort of the patient, I try to do subepithelial connective tissue graft, so leave the epithelium on the surface, but unfortunately these approaches were not really successful, most probably because the subepithelial connective tissue graft doesn't really have the biological information of creating epithelial tissue. So let's skip to the partial epithelial connective tissue graft, which again seem to be less invasive compared to the ECTG. So according to this nice drawing from the book of Donos and Renata Simões, what we could see that we leave just a tiny bit fringe of epithelial tissue, and all the rest we take out of the palatal side. So this is subepithelioid, and that is epithelialized. So we presume that since we leave a lot of epithelial cover on the palatal side, that will be more predictable and less invasive. Unfortunately, yes, we had some nice result of this PECTG graft, but unfortunately the morbidity was not significantly decreased, the donor site morbidity. So the result is nice, but morbidity is pretty much similar to the ECTG. So let's skip what other alternatives we have. So what is the summarize? What is the disadvantage of autografts ECTG, which is the gold standard? The results are predictable. The post-op contraction is quite low, almost none. It's autologous and it's free of charge. The drawbacks that we have to open to surgical area: the postoperative pain is quite considerable, limited volume, and color discrepancies, as you've seen in the previous slides. Of course, in the non-aesthetic zone it doesn't matter, but we still need to work on aesthetic zone. So what other alternative do we have? We have allograft. We've done some surgeries with allogram, which was quite successful, but as you see in that picture, out of this amount of allograft, unfortunately, due to the considerable shrinkage and the contraction of the graft, which was more considerable compared to ECTG, it didn't completely fulfill the requirements of the graft. On the other hand, in Europe, for example, in Hungary, as far as I know, in Germany as well, it is sort of not allowed to have it in the market. So let's have a look into xenograft in the third part of the lecture. So what do we have? We have these two materials in the market, and I would like to talk on mucoderm because I have more and more satisfying results with mucoderm. So what is mucoderm? Mucoderm is a botiss-made material. It is a xenogenous 3D collagen matrix from 1 and 3 type of collagen. It's from porcine, so not from bovine. That might be important information later for the test. They had a quite quick rehydration time. Actually, it's very fast. The remodeling, according to the manual, it's 6 to 9 months, so it's quite long, which is we're quite happy with. According to preclinical studies from Adrian Kashal and also Daniel Rotenau, we have this material has a very nice attractivity to fibroblasts and osteoblasts, and the angiogenesis is quite fast and swift. And of course, according to nice results from Adrian in the literature, we can see that this material is used successfully in periodontal plastic surgery. So let's have a look how this material works in another settings and peri-implant settings. So in the first picture, you could see again a huge alien, I would say, here in the upper left quadrant. So mucogingival line is pretty much coral, and instead of being here, and if we would like to place implant there, of course we need to increase the amount of keratinized tissue. So why do we have that loss of keratinized tissue? Because obviously we've done, as the previous case, a considerable amount of GBR, bone augmentation, and sometimes with sinus floor augmentation as well. So after the bed preparation, so the previous slide, you can see in the right hand side, there's a split thickness flap preparation that's quite crucial. So you will see it in more details in later slides, step by step. We trimmed and rehydrated the mucoderm, placed on the recipient bed, quite nice amount. Imagine if it was ECTG, it would be quite painful for the patient. And with tight contact on the periosteum, we sutured and immobilized it with periosteal stitches. So after 2 weeks, what we could say is the angiogenesis is quite fast, the maturation is quite fast, and after a few months we were able to place this Straumann bone level and soft tissue level implants. So when we deliver no separation, whatever, occurred. Now, if you see in the upper right picture, we have a nice amount of width of the keratinized tissue, which is 6 millimeters in that view. So prosthetics has been delivered, and as you see, we still have, after 6 months, a nice 4 to 5 millimeter keratinized mucosa around the implants. So we have a lot of replacement materials. The question is what to do and which situation. So for that, we conducted a pilot trial in the department, which we presented in the ITI symposium. We did some allograft and xenograft in order to recreate the keratinized gingiva, and just show quickly the results of this pilot. So this shows us the width of implant keratinized mucosa at the final result, because that is what clinically important is, whether we have the more than 2 millimeters or not. This FGG, which is an autograft, we've seen is 3.5 millimeter. None of the other material like xenogen collagen matrix, allogenic dermal matrix, or CTG. Only the xenogenic dermal matrix, which is the mucoderm, was able to come shoulder by shoulder in terms of the result with the ECTG. So the result was 3 millimeter. So what we decided, okay, so let's try this material, go ahead and conduct a more wide case series, which we did and presented at the Europerio from the research group in the department, and just some slides of the inclusion and exclusion criteria what we have. So the most important thing was to have patients with less than 2 millimeter, so less than sufficient per implant keratinized mucosa width. So how we done the surgery? This is not the surgery. This is the beginning situation, how all started. So usually the situation is started with a nice GBS surgery. So we can, after creating the hard tissue, we end up with a nice hard tissue but lack of soft tissue, lack of keratinized gingiva. So this is a very typical situation after GBR, at least here in Budapest. So what we can do is we can see that the mucosa is very mobile and very shallow vestibule. So did the first incision, which is at the mucogingival line. It was very important. There's a split thickness flap preparation to prepare the bed for the mucoderm, which has been trimmed and rehydrated and tried to have the correct size. And then, by the way, you can rehydrate in either blood or saline. We don't have evidence of literature which is better. Of course, if the patient bleeds and we have enough autogenous blood, I would prefer that. And this is quite crucial, in my opinion, to try to tuck this material under the epithelial fringe, or at least in a tight contact. Corona, that was the first layer of suturing. The second layer of suturing is the periosteal sutures. So we immobilize the tissue apical to the apical periosteum. So we don't suture any other ways as in the apical part. And of course, the mobile fringe should be sutured in the way of continuous sutures, in order to leave it uncovered. So it's quite important to leave it uncovered, this material, which works quite nice. And if you have a look, and this is the 6 days post-op picture. So while I was quite astonished that in 6 days it looks like, of course it's not very nice, but at least the patient took our advice to refrain proper or hydrogen plug control. But these are new vessels. So the invagination of vessels and angiogenesis is really quite fast, as we've seen in vitro studies. So let's check this 3 months result. We have a nice width of keratinized tissue with 8 millimeter-ish, and a 6 and 12 months result. When the 6 months result and the 12 month result, when the prosthesis has been delivered, we can see that we still have the 2 to 3 millimeter keratinized gingiva backlit to the implants, and the X-ray shows quite stable bone levels around this Straumann bone level implants. So the results of the study was okay. The computer program doesn't work exactly, so this lecture, the PPT, is not exactly the same what in my computer. So there's a lot of modification, unfortunately, in the web, but doesn't matter. The most important information is here. which is that the per-implant keratinized width, so we can't see the graphics of the table, out of 0.8 millimeter, which was the baseline, at 6 months, a half year later, we reach almost 3 millimeters. And in 12 months, so when the most of the shrinkage occurs, it's still more than 2 millimeters. So the shrinkage was only 0.2 millimeter, which is not really much. And of course, there's a statistical significance between baseline and 6 and 12 months. Now we're going to show more results and wider results of a wider, broader study on the uroperio. So not because of this, but because of other reason, I encourage everyone to come to uroperio and meet there in Amsterdam. So the results are the results of this study was that we reached a nice amount of keratinized mucosa in other patients as well. Now this is the lower jawbone, and this is a little bit compromised. So as you see, we still had a nice huge amount of mucoderm. But as the result, as the 6 months result shows, the shrinkage was quite considerable. And this is what we see in the lower jawbone. It's less predictable than in the upper jawbone. So it works, but it's not as predictable. So therefore, the combinative treatment, it's quite advisable. So this is what I would like to show you. So combination of ECTG and mucoderm. We call it strip graft, and this is why we call it that, because this is a nice tower in Balneário Camboriú in Brazil. So this is like a strip, very high but very narrow. Maybe this is the origin of the strip graft. So if you have a look at the clinical situation, we have only 2 to 3 millimeter keratinized gingiva. So we did the nice split thickness flap preparation, and we took a very narrow layer of a strip from the palate, which is 2 to 3 millimeter. Okay. Then we created our centipede. Looks like a nice centipede in the palate, and we placed here to the apical part of the recipient area, and in between the mucogingival junction and here the graft, the epithelial graft, we placed the mucoderm, the xenograft, and as a result, the most important part in order to reduce the contraction, the resorption of the graft, we placed like a stop line, like a barrier, the ECTG, the autograft, but just a very narrow layer, and the whole lot has been replaced by mucoderm. So we did not need to open and remove such a huge chunk of tissue from the patient palate, which he was very happy with. After 3 months, we found quite similar result compared to ECTG. So like we have taken a huge and nice big graft, and the 6 months result show thick keratinized tissue, again 6 to 7 millimeter thickness of periodontal attached mucosa, and the 1 year result, prosthetics is delivered. We still have a nice amount of keratinized tissue. To be honest, it's even more than we usually really want. But actually, this patient is left to Caribbean, maybe for good, or just for a couple of years. And now this patient is good oral hygiene, but whatever happens with her, I'm safe. I feel safe because the anatomy has been reconstructed. So if the patient finds out that getting more reluctant to brush teeth and rather drinking some nice rum in the Caribbean, we still have nice and firm implants. So the question again at the end of the lecture, what and how to do, and this is my conclusions. So natural teeth without keratinized gingiva is less easy to clean, therefore more prone to pulpa control and inflammation. Implants without keratinized tissue is more vulnerable to inflammation. Sufficient amount of peri-implant keratinized mucosa could be recommended from the long-term success of implant, especially aesthetic zone, and in case of improper oral hygiene, which unfortunately we try to teach the patient how to present with a good plaque score. Unfortunately, not 100% of the cases is like that. The most predictable graft material is still ECTG, therefore it should remain as gold standard. Nevertheless, in many cases, ECTG could be simplified or completely substituted by xenograft material, strip graft, or mucoderm. So this is a subjective guideline. As you can see that the outline of this slide has been modified during the time. Nevertheless, the ideal timing of replacement after GBR, so it is 3 to 6 months, but prior to implant placement. In the upper jawbone used in the practice and the department of the university could easily be used mucoderm per se. It could be PSCTG or strip graft, but mucoderm is quite predictable. The lower jawbone, ECTG, PSCTG, or strip graft with mucoderm is more predictable. Of course, we can use only mucoderm. In some cases, it works perfectly, but we do not know which cases the reconstruction, recession is a little bit higher than expected or desired. And once the implants are uncovered, since this is more less predictable, autograft might be more recommended than xenograft. And in aesthetic zone, because of ECTG doesn't have that nice color match, mucoderm is more recommended. And again, whatever graft you use, immobilization of the graft, nice, neat surgical technique, and tight contact to the periosteum is quite pivotal. This mucoderm, it could use for various reasons. It's not only for keratinized mucosa widening, but also thickening. We use for ages. We have a couple years data on overreach preservation, which is quite used, point-to-side development, contour augmentation, and we tend to use sometimes on GBR working as a thick and slow resorbable membrane as well. Now, before we go to the 10 minutes question, I would like to show a case in order to a little bit go back to relax and just to see not pure treatment, different treatment guides, but just to have a look on the clinical situation. This is a clinical situation in the perio patients. Of course, we do perio first, but once the perio is stable, then this patient is ready for tooth replacement with implants. Certainly, we do need to do some GBR procedure, as in this picture. Now I'm showing only the left-hand side of the patient. So we've done an external sinus lift surgery with xenograft, and like in this situation, we've done the cerebone from botiss mixed with autogenous bone, actually large Greek xenograft in the sinus and small Greek xenograft mixed with autogenous bone particles around. So a contour augmentation and lateral augmentation have been done. Resorbable membrane, mobilization of the flap, and I think again the suturing is very important in order to have a tensionless closure. Therefore, we aim the three-layer suturing in this situation, and after 2 weeks we can't even see the incision line. This is the lower jawbone of the same patient. So 4 months after GBR sinus lift, we wanted to place implant, and according to this stand, we see that this patient doesn't have any peri-implant kind of keratinised mucosa, or at least it's not enough. So we took a graft from the palate. This is nice strip graft, as you can see from the centipede on the right hand side, and the strip graft is placed apically on the recipient area. Then we use the mucoderm for in between the strip graft and the and the previous mucogingival junction, rehydrated with blood in this situation. We have a small video on the after the surgery, where we can see that immobilization is very, very important. So I moved the buccal part where it was non-vestibular, and now it's absolutely immobile. So let's skip to the next slide, please. Thank you, Razwan. Perfect. So this is the same surgery for the same patient. So remember, we took the strip graft on the palate and put it on the lower left hand side, and here adjacent the upper left hand side we placed only a mucoderm, because in this situation that was totally enough, and to do this surgery in the same time would reduce morbidity. So 4 months results, nice 10 mm keratinized mucosa in the upper jawbone. We were able to place the implants. Remember, this was only mucoderm in this side, and see how thick buccal soft tissue we have here, keratinized mucosa. A lot more than 2 mm. This was beginning, and this is the lower jawbone, which was the beginning. And see, we've done strip graft with mucoderm, how it looks like now. Again, we have a nice 10 mm thickness, width of mucosa. So place the implants. They did some contour augmentation with cerebone and jason membrane with a booster method, with a combined graft, autograft and xenograft, resorbable membrane, and again see the amount of soft tissue, keratinized tissue we have 6 months after the soft tissue grafting. So I know this surgery is not very easy, but if I learned, everyone could. So be patient, do as many surgeries as possible. If you want, we do a lot of trainings, hands-on training in our department. We're gonna have one in right after Europerio and the last week of June. So please feel free to contact us if you would like to join. And I would like to quote the Liverpool manager Bill Shankly, what he said: "Some people believe that 2 mm per implant keratin mucosa is a matter of life and death." I'm very, very disappointed with that attitude, because I can assure that is much more than important. So I can't disagree with Bill Shankly. So the first question we asked an hour ago, keratinized mucosa, does it really matter? So I think the answer is yes, it does. So with that picture of Budapest, I would like to thank you very, very much for your time being with me on this sunny evening, and I open the floor for the questions. Thank you. Okay, quickly, implantoplasty, yes. In that first situation, actually, I think the ideal candidate to implantoplasty, we can talk hours on peri-implantitis treatment. Now, non-surgical treatment, as we know, is a good approach at the very beginning, but for long run, this is not predictable enough. So we need to do some surgery in case of peri-implantitis. GBR, well, it might work, might not. But I know from the peri point of view that periodontal regeneration around this doesn't work all the cases. So an implant situation, which is a very, very very difficult and less predictable procedure because of less blood support, that is less predictable. So in that case, I think resective surgery is what we usually predict. So bone level around the bone, below the bone level, so infrabony site, we can try some regeneration if we can remove the infection, but above the bone level, above the bone crest, of course, only resective surgery, which means implantoplasty. But unfortunately, the best treatment of implantoplasty is explantation, and I believe the very best treatment of implantoplasty, implantitis, is prevention, like placing implant in enough hard and soft tissue. Okay, the result I show in our research, there were pilots so no point to talk about statistical significance. What we are conducting now, that's more powered, so we will see the statistical significance. In the periopac, thank you for noting, we don't use any periopac or copac on the grafted sites because I believe that that is more plaque accumulation and less cleanable for the patient. So the post-op regime remains antibiotics, medium, and the chlorhexidine rinsing of the patient, and of course refrain from brushing. FGG, yes, it's ECTG, as I said. Can we prefer connective tissue graft or mucoderm? Healing time, it's an excellent question, Andrei. Usually we try to be concise, so according to the biology of these tissues, is not recommended to go back on the situation for, I would say, at least for 8 weeks. So 8 weeks is necessary for soft tissue to mature. So I wouldn't recommend do any evaluation earlier than 8 weeks. So 2 months or 3 months is enough, and the maturation we see in 2 to 3 months, and both ECTG and xenograft works nicely after 2 to 3 months. Thank you, Ricardo and Susan. Well, Danielle, you might remember the huge contraction it occurred with allograft, with allogram. I wouldn't say there's a huge contraction with mucoderm. It's very good that you answered the question. Maybe I was not very clear. So in terms of contraction, the best is the gold standard, which is ECTG, or say FGG if you would like. Then mucoderm is predictable. If you would like to stay on the safe side, use with combination of a strip graft, so with an ECTG, because that is very predictable. And if you use mucoderm only, I could say that in the upper jawbone is absolutely predictable. So I don't think contraction is a matter. Of course, you can take at least 10 millimeter thickness, width of graft of mucoderm, because you open a box, it doesn't matter if you cut 2 millimeter or 10 millimeter. So I would recommend to leave at least 10 millimeter, and then most of the cases will reach the approximately 3 millimeter for the long run. Okay, I think I answered all the questions, so you've seen my email address. If you have any questions, or if you disagree, then of course I'm open for that. And again, I'm very grateful to you guys to be with me in this nice spring evening. So thank you very much for your kind attention, and I wish you a nice evening. Bye bye. Ciao.